What's up, ladies and gentlemen? Welcome back to NeuroSketch with Dr. Kenny. But if this is the first time you've seen this channel, don't forget to subscribe. Today, we're going to discuss the cervical vertebra, the cervical spine. And the cervical spine is this part of the vertebral column that is falling under the neck region. The part of the vertebral column that is falling under the neck region is called the cervical spine. The cervical spine is made up of individual vertebral bones, which are called the cervical vertebra. We have 7 cervical vertebra denoted by letter C's, meaning we have C1 through C7, and the cervical vertebra is the secondary curvature, the secondary curve, meaning it wasn't present early in development. It starts to form around 3 to 4 months when the baby starts to hold his neck. When the baby starts to hold his neck, the cervical spine is curving a little bit backward so as to support the head, and as a result, if you're looking anteriorly, you will find it is convex anteriorly, and this convex shape is called the cervical lordosis. Cervical lordosis is that shape of the cervical spine because it's curving a little bit backward to support the head when the baby starts to hold his neck. The cervical spine is the most mobile part of the vertebral column. The most mobile part of the vertebral column is the cervical spine. And you guys remember, the higher the mobility, the lesser the stability. As a result, the cervical region, the most vulnerable region of the vertebral column to injuries. The most vulnerable part to injuries or susceptible to injury is this region. And why is it susceptible? Because of highest degrees of mobility, which makes them a little bit unstable. Okay, what are the general features of the cervical vertebra? Let me take this one as an example to start the general features. Let me take this one as an example, C4. We're going to discuss each one, the general features, which can also be referred as the typical features of the cervical vertebra. I'm going to start from anteriorly moving backward. So anterior of the body of the cervical vertebra is expected to be small. Is expected to be small compared to the lumbar and to the cervical and the lumbar. To the thoracic and lumbar. And why small? Because we said the vertebral body is the weight-bearing part of the body, and because the ability of weight bearing is increasing as you are moving downward. This cervical vertebra, because they're placed higher in the vertebral column, they bear minimal weight, and compared to the thoracic and the lumbar, and this is why they have their bodies are very small compared to the mentioned above. Again, the body is also having two on the lateral part of the body. We have two projections, two bony prominences, which are called them anchors or uncinate process. We call anchors or uncinate process. It's very, very important, this bony projection on either side. When you take a look from this position, you will see we have these bony prominences, which are called anchors or uncinate process. The anchors process is fitting into indentation of the, we have something like a depression on the inferior part of the vertebral body. So the anchors is forming a joint or a junction, with the vertebral body above, in which we have indentation. Let me show you here. Like we have something like a depression, something like this. So the anchors process is fitting into this indentation to form a joint, and this joint is called the joint of Rushika. But because the joint between the anchors process and the vertebral body, it is called the ankle vertebral joint. Ankle vertebral joint, or the joint of Rushika. This is the joint we are talking about. Wow, it's called the joint of Rushika, which is also called ankle vertebral joint. Why ankle? Because we have a joint between anchors, which is also called the uncinate process, and the vertebral body, and this joint is called the joint of Rushika. The joint of Rushika is very important because it is important for stability. Actually, this joint is helping to avoid sliding. It avoids sliding of the vertebral bodies of the cervical vertebra. It adds a little bit like it adds stability, avoid sliding or slipping of the vertebral of the cervical vertebra, so as to increase the stability. Yeah, so this joint is called the joint of Rushika, which is also called ankle vertebral joint. That is the vertebral body. That is the vertebral body of the cervical vertebra, typical cervical vertebra. Another Important thing, let's talk about the foramen here, which is the vertebral foramen. The vertebral foramen of the cervical vertebra is expected to be wide, but most important, triangular. Why is it wide? We said we have an enlargement of the spinal cord at two important regions. Number one, in the cervical region. The cervical region of the spinal cord is enlarged. Also, the lumbar region is enlarged. We have enlargement at two important regions, the cervical and the lumbar. Why enlargement of the cervical region of the spinal cord? Because of formation of the brachial plexus. We're going to form the brachial plexus from the spinal cord, the spinal from the spinal cord, which is falling at the cervical region. Also, we have to in the lumbar region, we are going to form the lumbar plexus to supply the whole of the lower limb, the structures of the lower limb. So we have enlargement of the spinal cord there. We have enlargement of the spinal cord here, so as to form the brachial plexus. The brachial plexus, they supply the upper limb, the whole of the upper limb. This is why we have enlargement at this point, two important regions. As a result, because of enlargement of the spinal cord, we should also have enlargement of the corresponding vertebral foramen, so as to allow this to accommodate this expanded spinal cord, because we don't want the spinal cord to be compressed. Otherwise, it would be easily compressed. That's the vertebral foramen. Again, let's discuss about the transverse processes. The transverse processes of the cervical vertebra, they are expected to have foramen. These foramen, we call them the foramina transversarium, which means foramina transverse foramina, or the foramina transversarium. Why do we have this one? We have this one because we have this foramen that we transmit arteries. We have arteries that we go through, arteries and veins that we go through this transverse foramina, and this artery we call the vertebral arteries, and the vertebral veins, vertebral arteries and veins that we go to supply the posterior part of the brain. Don't worry about where it goes, but at least you know that it passes through the transversarium foramina transversarium. Yeah. Another important thing about the transverse process is that it terminates after being perforated to form a foramen, which is transversarium foramina. The transverse process also gives like bifurcation. It forms two important tubercles. We call them tubercles, anterior tubercle and posterior tubercle. We have anterior tubercle and the posterior tubercle. And the anterior and posterior tubercle, these are the site of attachment of different muscles. Any muscle that you mentioned that this muscle is coming from the the transverse process of C1 to C4, for example, the vertebrae scapulae, or you can also have muscles like scalene muscles, anterior, middle, and posterior scalene. You say these muscles are coming from the transverse process of C whatever vertebra. This is where they are coming from, the either anterior tubercle or posterior tubercle of the transverse process. Again, between the anterior tubercle and the posterior tubercle, we have a depression here, and this depression is called the depression of a spinal nerve. Remember, guys, the spinal nerve is passing, the spinal cord is passing through the vertebral foramen, right? But as it passes through the vertebral foramina, which is now vertebral canal, it gives branches, it gives spinal nerves. And we've already seen how spinal nerves are formed, like the dorsal root and the ventral root, they joint form a spinal nerve, and the spinal nerve will divide into rami, anterior and the posterior ramus. And so the ventral ramus, which is also called the anterior ramus, is passing through this region here, and it is going through the ventral through the groove for spinal nerve. So groove for spinal nerve is actually being occupied by the ventral ramus. The ventral ramus of the spinal nerve, The dorsal ramus is going to supply the muscles of the back. We're going to see them again. So this is the transverse process. The transverse process is expected to have transverse foramina, but it terminates by forming two tubercles, anterior and posterior tubercles, but it has also got a groove for arteries, groove for nerve, which are called the groove for spinal nerves, groove for spinal nerve. Okay, let's turn the bone posteriorly to see the features on the other side. On the other side, posteriorly, we have the spinous process. The spinous process of the typical thoracic vertebra is expected to be short, but most importantly bifid. Expected to be short and bifid. But bifid spinous process is expected mainly from European population. White people, but especially white men. So white men, they have this bifid, the bifid spinous process, and we Africans, and most of dark skinned and black populations, we usually lack, most of, we have a variable degrees of bifurcation of the spinal process. So it's okay if you don't have. You can imagine, because it's common in white, but not only white men. You can imagine being black and also a woman. So they usually lack this bifid spinal, which is okay. Okay. Again, we also have the superior articular facet. This is common. We've already seen also in the other part of the vertebral column. Like we have superior articular facet, which will articulate with the inferior, articular facet of the vertebral body below to form what? So the superior articular facet will articulate with the inferior articular facet of the vertebral body above to form a zygapophyseal joint. It's called the zygapophyseal joint, or also the facet joint. Zygapophyseal joint and a facet joint. So you see, the typical thoracic vertebra are expected to form two important joints. Joint number one is the joint of Rushika, which is also called the ankle vertebral joint, but also the zygapophyseal joint, or which is also called the facet joint. These are the typical features of the typical features of the cervical vertebra. The cervical vertebra can also be, the cervical spine or cervical vertebra can be divided into typical and atypical. The typical cervical vertebra, we've said we have typical features. We've seen the typical features. We expect to find them with these typical features. But atypical ones, they little bit deviate from the general rule. Maybe they have they don't follow the general rule, or they have something in excess. We're going to discuss each one in turn. The typical cervical vertebra are C3 through C6. C3, 4, 5, and 6. The remaining C1, C2, and C7, they are atypical, and we're going to see each one, why is each one of them atypical. Let's start with the C1. C1 vertebra is also called atlas, and I am curious, why is it called atlas? Okay, in Greek mythology, Atlas was a titan who condemned to carry the universe on his shoulders, as you can see. So he condemned to carry the universe on his shoulders, the universe, the heaven, or the globe on his shoulders. C1 vertebra, it is very small, as you can all see. It is very small, but it supports the skull sits on C1 vertebra, and it gives you this impression as the guy Atlas carrying the universe, and this is why C1 is also called an atlas. An atlas is one cervical vertebra, C1 cervical vertebra. And why is it atypical? Number one, it does not have the body, the body here doesn't have the body, but also does not have the spinal process. It lacks the spinal process, but it also lacks the vertebral body. It lacks the spinal process, but also lacks the vertebral body. As we have said, it is expected to support the skull. One of the bones of the skull, which is called occipital bone, we're going to discuss about the occipital bone at some point, but occipital bone has got occipital condyles, the condyles, which are going to fit into this superior articular facet of C1 vertebra to form a very, very important joint, which is called the atlanto-occipital joint. It's atlanto-occipital joint because a joint between atlas and occipital bone. This joint is a condyloid joint. Condyloid joint, remember, this is a synovial joint that have condyloid. You remember the condyloid joint. But the name of the joint is atlanto-occipital joint. The type of a joint is condyloid synovial joint. This joint is very important, and because the skull is moving against the atlas here in this fashion, so it gives this yes movement. When you are nodding to signifying yes, it's actually the atlanto-occipital joint which is in action. Why? Because of orientation of the facet of the joint, So you can see we've seen the C1 has got no body or the spinal process, so it gives like an arch. So we have basically the arch, we have the ventral arch and the the posterior, the dorsal arch. We don't have the body and the spinal process. But also it's very important when we have a groove here which is called the groove for vertebral artery. It's a groove, it has got a groove for vertebral artery. Another important thing, it has got the concave depression here on this part, and this concave depression is for articulation with the C2 vertebra. C2 vertebra, now it's time to talk about C2 vertebra. The C2 vertebra is also called an axis. And why axis? Because of this bony projection here, which is giving an impression of an axis, a vertical projection, but it's a tooth-like projection. And because it is a tooth-like projection, it is called a odontoid process. It's called dense, D-E-N-S, dense or odontoid process, because it's a tooth-like projection. This is what makes T1. This is what makes C2 atypical the most. C2 is atypical mainly because of the presence of this one. It didn't expect to have this one on its body, but you see it has got a little bit of like something like a bifid spinal process, which is okay. But why atypical the most? Because of presence of this one odontoid process, but also the orientation of the superior articular facet. We expect the superior articular facet to be pointing a little bit superior posterior or something like that, but this one is pointing like lateral, a little bit like lateral, so it deviates from what we know. We have said C2 vertebra is expected to form joint with C1 vertebra. So this joint is actually between the atlas, which is C1, and axis, which is T2. What is it? What is this joint? Okay, let me make it very clear to you guys. C1 and C2, they are making two important joints. The first joint is this one, the vertical atlanto-axial joint, because the joint between atlas and axis is called atlanto-axial joint, and this is the famous joint which is known. The atlanto-axial joint, the famous atlanto-axial joint, is actually the joint between the convexity of the dens of C2 and the depression, the concave depression of C1. It's usually reinforced by ligaments, some certain ligaments, which they form a ring-like, and it's called the annular ligament. And because of that, this joint now belongs to pivot kind of synovial joint. The name of the joint is atlanto-axial joint, but the type of a joint, the pivot joint. And because of this annular ligament, this C1 can only rotate against C2, in this fashion. And because of that, this movement is called the no movement. When you are saying no to your friend, is actually this movement. It's actually the axis is moving against the atlas moving against axis to rotate, and this is what makes that movement possible. But also you can see the C1 and C2, they also make another joint. It's not limited to that joint. We also have a joint between the superior articular facet of C2 and the inferior articular facet of C1. So we also have, this is also called this joint is also called the atlanto-axial joint, but they have like different, this is vertical, something like vertical, have different names, but the famous, most of people will want you to mention this joint between the dens and that part of atlas, and that part of atlas. We have seen why is C2 atypical. Now is the time to talk about C7 vertebra. This one. So C7 vertebra, it is atypical because number one, let's now start with the posterior, with the spinal process. C7 vertebra is atypical mainly because its spinal process is usually singular. It's not bifid. It's usually a singular spinal process, but also strong and prominent. We didn't expect it to be prominent. We didn't expect it to be long. typical cervical vertebra, we've seen they have short spinal process, but this one is long and a little bit, prominent, and it can be felt at the root of your neck. When you flex your neck, the very first bone prominence that you can feel there, that is C7 vertebra. Because it's very prominent, it's also called the cervical, the vertebral prominence. The vertebra prominence is the reserved name for C7 vertebra because it's prominent on the root of the neck, and that's why it's called vertebra prominence. But also other features that make this joint, that makes this vertebra typical also is the presence so they are transverse foramina. They are usually small or sometimes even absent. They're usually small or sometimes even absent, and they are not expected to transmit the vertebral arteries. They are not expected to transmit the vertebral arteries. The vertebral arteries, they usually skip C7 vertebra. They're starting from C3, C6 all the way to C1 we're going to see. But again, the transverse process, we expect the transverse process to terminate by forming two tubercles until the posterior tubercles for attachment of muscles. But this one, you see, it does not have anterior tubercle. So the spinal process is a little bit, enhanced laterally to form the ear-like projection, like the ears of the elephant, I think, something like that. You can see something like the ears of elephant. And we've already seen also that we can have the cervical rib, right? And remember, the cervical rib, we say the cervical rib is like an outgrowth, it's like overgrowth of the transverse process of C7. We said most of the cervical rib, they arise from C7 vertebra, the cervical vertebra above. Most of them, if it happens, you will find that it is connecting to this transverse process of C7. So the transverse process of C7, they are really lateral, and sometimes it can happen that they are they are overgrowing to form something like a rib, and it's called the cervical rib. So what can you say about C7 vertebra? C7 vertebra can be viewed as a transition from the cervical spine or the cervical vertebra into the thoracic vertebra. It is cervical in that it has got the transverse foramina, but also the upper part has also that Anker's process, and also the Anker's process, the uncinate process, which form this Rushika joint here. And you see inferior, it does not have that depression, the edentoid indentation for forming a joint, because this does not expect form joint with this one again, right? But what about transverse process? It has got a transverse foramina, which is typical for cervical spine of cervical vertebra. But look at the transverse process. The transverse process is usually started to behave a little bit. The transverse process of C7 started to behave a little bit like the spine, the thoracic one. Why so? Because the cervical spine, we've said the thoracic vertebra, the transverse process are usually strong. They're pointing a little bit backward, but they're strong for articulation of the ribs. And this one, you can see it start to form something like that. So C7 is actually a transition from, you're moving from the cervical spine, now you're moving from cervical spine into the thoracic spine, and so you have to behave. This thoracic spine, the cervical spine, can also be divided in two important groups. We have the upper spine, which has got two bones, the C1 vertebra and C2 vertebra, and the lowest C3 through C7, they are called the subaxial skeleton, the subaxial part of the cervical vertebra. Why subaxial? Because it's below the axis, subaxial, below the axis here. And you can now relate that only the subaxial spine of the cervical vertebra is the one that forms the Rushika joint, the joint of Rushika. The C1 and C2, they do not form the joint of Rushika. We've seen the joints of C1 and C2, they are different. They do not follow the general rule that the joint of the lowest part of the vertebral column of the cervical spine. All right, this is it on the discussion. I know we haven't discussed the clinical correlates that is falling under the neck region, but things like, for example, when someone is hanging himself, someone is committing suicide by hanging himself. They usually have a hyperextension of the cervical region, and so it can result into fracture of different parts of the vertebra of the cervical vertebra. And remember, we have the spinal cord which is traveling through the vertebral foramen. When you are hanging yourself, when someone is hanging himself, despite of having a fracture, you can also have injury to the spinal cord. And remember, the spinal cord, the spinal cord at this region is very important, because we say the diaphragm takes its origin from here. The diaphragm has got origin from C3, 4, and 5, and remember the C3, 4, and 5 keeps your diaphragm alive. So if you have damage of injury to the cervical spine, to the cervical spinal cord, which is falling under that region, C3, 4, and 5, you can have compromise to your respiratory system, and so that is also when this is also why when you find someone has sustained a motor traffic accident, motor traffic crash, and is unconscious, you are not sure whether the neck has got injury or not, maybe because the neck is the highest mobile part and the highest vulnerable to injuries. When you find someone is unconscious on the road in a motor traffic accident, we first of all have to immobilize the neck, like to stabilize the neck. You find whatever mechanism to stabilize the neck. Why? Because if we have fracture of the either of the vertebral fracture of this vertebra, we can when you now start to lift the patient, you can have traumatic injury to the spinal cord. And so because of that the diaphragm is coming from somewhere there, you can have injury to the diaphragm, and you can cause harm to the patient more than help. Like you went to help, but you find like you have caused troubles, and the patient can die on your hand. Yeah, so this is it about it, and see you soon. Oh, sorry, we haven't seen the arteries. We haven't seen the arteries that are passing through the vertebral, the transverse foramina. Yes, we have said we have the transverse foramina, and we have said the transverse foramina, they are transmit the vertebral artery. The vertebral artery is the second is branch from the first part of the subclavian artery. We're going to discuss about subclavian artery at some point, but the first part of the subclavian artery is given bilateral, is given the vertebral arteries, and the vertebral arteries that are traveling through the transverse foramina, and especially we've said it skips C7, so it doesn't go. You can all see this. The transverse foramina of C7 are usually left blank, and the arteries is traveling from C6 all the way to C1, and we've said when it reaches the level of C1, it passes here to form it passes here, and this groove we said is a groove for vertebral artery. C1 has got a groove for the vertebral artery. They usually go with their corresponding nerves, with their corresponding veins. So we have the veins that are passing through in a similar fashion. We have a question, additional comment. Don't forget to put your thoughts in the comment section, but you can always swing by Instagram and TikTok account, where we put a lot of learning material to help us to memorize and remember easily. Yeah, see you very soon.